Here's something else we're paying for, executive compensation. Look at those numbers. You know, the executive can learn as much, in some places the CEO can earn as much in 5 minutes as the janitor who keeps that building clean can earn in a whole year. So, I don't think that's right. There's one of the guys who got collected all that money. So as I said, the medical industrial complex, that term first used in 1980. And here's what their motto, what the rest of us call healthcare costs, they call income. Or another way a guy I recently met put it, who used to work for one of the health insurance industries, one of the companies, we're not in the business of paying claims, we're in the business of collecting premiums. That's how he put it. Okay, so this is a picture of the healthcare reform in Congress. Lots of money going into it and blinding them. So this is, again, the picture of the uninsurance. So this is one of the consequences of uninsurance and underinsurance bankruptcy, medical bankruptcy. More than 60% of all cases of bankruptcy in this country are caused by illness and medical bills. This happens very seldom in other countries. Canada has maybe 10% of what we have in medical bankruptcy. That's because people lose their jobs and lose their health insurance. That needs to be fixed. But here, most of the people who went bankrupt were middle class, and more than 75% of them had insurance at the time they got sick. They still went bankrupt. Either they lost their insurance, or they had their insurance, but their out-of-pocket costs, their co-pays and deductibles, were enough to drive them bankrupt. I mean, people have had 2 kinds of insurance and gone bankrupt. So this compares insurance premiums, the top line, with the second line is workers' earnings, and the bottom line is overall inflation. You can see how much healthcare costs are going up. And that's just premiums. That's not the whole of healthcare costs. Another slide that shows that the cost of insurance premiums, before you ever get any medical care, just the premium, that the cost curve is going to intersect with the curve for family income. Okay, so this is just another slide about this, how the cost of insurance premiums compares to what people are earning. Skip. Okay, so this compares overhead spending in different kinds of insurance products. At the far right, we have Medicare. Some people put it even less than 2%, but anyway, it's really small.
Move your cursor a little. Move your cursor up a little bit. That way you can go back.
Oh. Then you have the not-for-profit blues. Not-for-profits, maybe when it comes to insurance, there's really no difference between not-for-profits and for-profits. Why? The not-for-profits have to behave like the for-profits, or they get all the sick patients and they go broke. So they all behave the same. Investor-owned plans, you know, more than 25% of what they take in gets used for overhead, not to pay for medical care. There are some insurance products that are worse than this. Some of the insurance products that are sold at colleges that the students are required to buy, they might have, and we call this the medical loss ratio. That's the percentage, that's the insurance industry's term, that's the percentage of what they collect that they pay out for medical care. That can be 30, 35% for those college plans. Of course, they're not very expensive compared to plans for other people pay, but why should you be paying $3,000 a year for, you know, $100 worth of medical care? So, Medicare, far lower overhead. See, I'm going to skip this because it comes up again. Okay. So in the United States, so we're looking at several other industrialized countries, all with excellent healthcare systems. Those pale green lines, that's the total spending in those countries for healthcare. Then you come down to the United States, and the yellow is our public spending. Not our whole spending, that's the whole line, our public spending. What does that entail? Medicare, Medicaid, veterans benefits, the cost of government employees and retirees, their health care, and the tax deduction that employer-sponsored plans get when they pay for insurance for their employees. All of that comes to more than any country, probably except Switzerland, in the whole world, spends in total for their medical care. So we are paying for national health insurance, but we are not getting it. Okay, Medicare for all. We say that under Medicare for all, a single-payer plan, we can spend as much or less money, cover everybody, and improve everybody's benefits. And how can we do that? Well, primarily by lowering administrative costs. In our system, it's that those multiple insurance companies that give us our huge administrative costs. 30% of all healthcare spending in this country goes for administration. That's actually an old figure, and my suspicion is that it's more than that now. So that you take that administrative cost and just cut it in half. Cut it down to 15%. That's enough to take care of everybody and to expand everybody's benefits. You get rid of all those people who are there finding ways to not pay for your health care. It's cheaper to just pay for it than to have a bunch of people sitting there finding out ways to not pay for it, while on the other side there are people trying to find ways to get paid. You just get rid of all that and you have enough money. Then there are some other things that we would do. We have what's called global budgeting for hospitals. So that means every month the hospital gets a lump sum to take care of their group of patients. And there are ways to determine this. This is kind of done in some ways already. So it's not something that's new. They get a lump sum. Every time they give you an aspirin, or they start an IV, or they draw a blood test, they do not have to send that information to the accounting office to be put on a particular patient's bill. We all know, I'm sure you've gotten bills from hospitals that were full of errors. It's going to happen. If every time the nurse does something for you, she has to take this little barcode thing and put it on your chart, and it has to go to the accounting office. You know that's going to get screwed up. You don't have to do that. You have to keep track of people needing aspirin, but you don't have to send it to the accounting office. That's a waste. So that's one thing you get rid of. Then this single payer, this government entity, this Medicare, bargains with the insurance industry for reasonable prices for drugs. They can make a profit, they can make a fair profit, but they don't get to make enormous profits. They bargain with the companies that manufacture medical equipment, defibrillators, wheelchairs. They bargain for reasonable prices. And the physicians and the home health agencies, we too negotiate with the government to get fair prices, but we don't have to have doctors getting wealthy. I think doctors, including me, should make a good living. We don't have to get rich, okay? That's how you save money. Okay, this is a complicated slide, but it just shows that you take in the extra things that we would have to cover, covering the uninsured, getting rid of co-pays and deductibles, extending everybody's coverage, and then you take out the things we won't be paying for, including especially administration, you actually end up saving money. So we can have better coverage for everybody for less money. So I mentioned that, global budgeting in hospitals, capital planning. When there's already one hospital in a neighborhood, you don't build another hospital right there because it's a wealthy neighborhood and the two hospitals want to compete for the most profitable procedure. You don't do that. The hospital gets built where it's needed. That's what you do. That saves money. You don't have 10 MRIs in one place and no MRI machines in one place and none in another. You have too many MRI machines, and then the administration is bugging the physicians to use the MRI more so that they can make up their costs. So you don't need that. I mentioned those. So what is it? Is it socialized medicine? First of all, I hope we get away from this superstition about if it's socialized, it must be bad. And let's examine the evidence for what we're talking about and see things. And we're not talking about doctors salaried by the government, although some people think that's a good idea. That's how the VA system works. The VA system has the best medical care in this country. The hospitals are not owned by the government, but the Cook County Hospital can stay the way it is, but get paid for taking care of people. So it's a we're talking about a publicly financed system with privately delivered health care.